Good evening, my name is Molly and my topic will be on the compliance and role of elastin and the effects of emphysema as well as smoking. So we'll begin with the physiology of the lungs. The lungs are comprised of the main bronchi seen through here, supported by rings of hyaline cartilage. They also have lobar and segmental bronchi, composed of cartilaginous plates, as well as bronchioles, which are pulmonary air passages that lack cartilage but have an abundance of things such as smooth muscle, elastin tissue, and have a simple cuboidal epithelium. The apex of the lung is seen up here, as well as the base of the lung here. Other things that are important are the respiratory bronchioles, the alveolar ducts, and the alveolar sacs that you can't see in this image right here. So the alveolus is a microscopic air sac of the lung. The alveolar macrophages phagocytize dust particles in the lung, which is important for lung functioning. The respiratory membrane is dry through absorption of excess liquid by the blood capillaries, and the lungs have the most extensive lymphatic drainage of any other organ in the body. So you can see the alveolar up here, it's located, the bronchial cartilage, and the branches of the pulmonary artery seen lower down. The pleura lines the thoracic wall and forms the surface of the lung. There's visceral and parietal pleura. The visceral pleura is seen here, with the parietal pleura a bit lower here, and the pleural cavity is in between. In this image, it's seen as quite large. In a lung such as yours or mine, there wouldn't be a gap that big because our lungs would be inflated, occupying that space. The functions of the pleura is to reduce friction, create a pressure gradient, and for compartmentalization. Elastin. So elastin, or the role of elastin, is pretty much in its name. It's thin and it's flexible. It's located in the pleura, the blood vascular system, the bronchi, the respiratory units, pretty much everywhere in the lung. The coiled structure allows for it to stretch and recoil when tension is released. And this elastin recoil drives expiratory flow, which is important in determining ventilator functioning. Elastin is required for normal lung development and is tightly linked with alveolar functioning. And the destruction of elastin or abnormalities in elastin fiber are major function factors in diseases of the lungs such as emphysema. So elastin is an evolutionary innovation. The energy is created during contraction of the diaphragm, during inhalation, which is stored in the elastin tissues of the lung. This stored energy in elastin is released when the lung is recoiled during exhalation. So therefore, damage to elastin fibers is quite detrimental to lung mechanics and efficiency of the respiratory system, since it has such a large role in both inhalation and exhalation, essential for us to live. Cross-linking is found in elastin, which is essential for proteins insolubility and longevity. There's minimal elastin synthesis in tissues as adults, which explains why damage to elastin fibers in the adult life is extremely detrimental, and why it is so important for elastin fibers to have such a long half-life. So this image here, the dark region here depicts cross-linking, which is associated with microfibrils, which facilitate elastin assembly. The red arrows here just show the microfibrils, and the green arrow shows that elastin provides information to cells when integrating with signaling receptors. Some abnormalities are COPD, so chronic obstructive pulmonary disease. Two main things comprise COPD, and that's emphysema and chronic bronchitis. I'll be focusing on emphysema. The main cause of COPD is long-term exposure to substances that damage or irritate the lungs. So quite an obvious factor would be cigarette smoking. In this image here, you can see that in a normal lung, airflow is quite easy. There's a wide passage and the alveoli are nice and plump. COPD shows an obstruction of airflow with the alveoli being hyperinflated, and the alveolar wall is destructed with loss of elasticity. So an alveolar comparison, on the left here is a normal lung, on the right is a lung showing emphysema, or alveolar showing those two things. Normally, alveolar should be thin, thin respiratory membranes and small. In one with emphysema, the alveolar membrane breaks down and neighbouring alveoli join to form larger, fewer alveoli. So this reduces the surface area, which of course is going to be detrimental in the functioning of the lung. So in emphysema, by definition, emphysema is the permanent enlargement of the air spaces distal to the terminal bronchioles with destruction of the walls. So obviously there's abnormal elastin fibers, and there are two types of emphysema. The first being centrilobular, which is the dilation and destruction of the respiratory bronchioles. And this is the most common type of emphysema in COPD, most prominent in the upper zones of the lungs. The second type is panlobular, where the destruction of the whole acinus occurs. So this whole region here is destructed. That's more seen with antitrypsin deficiencies and in the lower regions of the lung. So I'll just briefly touch on protease, anti-protease imbalances. So when enzymes damage the elastin in the lungs, it obviously damages elasticity and ventilatory function, which is extremely detrimental to lung functioning overall. So you can see here in a healthy lung what that should look like. As someone starts to smoke cigarettes, for example, harmful particles can become trapped in the alveoli, which triggers an inflammatory response. These chemicals dissolve the alveolar septum, so the large air cavity is then lined with carbon deposits, which forms this dark colour, and you can see the difference there with a normal lung and one with emphysema. So the protease anti-protease imbalance occurs when there's a shift directly corresponding to the injury of elastin fibers. The proteolytic enzymes will then produce emphysema. Homogeneous AAT deficiency who smoke develop emphysema from a young age. So on the previous slide when we spoke about there being two different types, the panlobular is a result of this, to do with enzyme, specifically the antitrypsin or AAT deficiency. Smoking. So smokers with COPD have elastin degradation, which is linked with emphysema. So typically someone who smokes has a higher risk of developing emphysema than a non-smoker. Tobacco smoke itself will probably stimulate elastin microfibril deposition by dermal fibroblast. So there are detrimental effects of tobacco smoke, and these findings are extremely important in COPD. Exposure to tobacco smoke correlates with higher rates of emphysema and lung diseases. So in this slide here, you can see a non-smoker's lung compared to a smoker's lung. We've all seen this image, but I think it accurately represents my whole presentation. So thank you. I would ask for any questions. And here are some of my references.